Well, welcome again, everyone. We're glad to have you join us for this session of slide review and sign out. I'm Louis Hassel. I'm faculty at the University of Oklahoma Health Sciences Center in Oklahoma City, Oklahoma. However, today I'm coming to you from New Hampshire in the United States, doing a little bit of remote work. And so I'm dealing with a little bit of new technology in terms of doing this from a different location. So hopefully everything will work well. I'm going to ask that as you have questions as we go along, that you please enter those into the chat so that when we come to the end of the program, I'll be able to review that and make sure that we've answered all of those questions as we've gone along. So our cases today are a variety of cases from the realm of gynecologic pathology.
I've prepared some interesting cases to discuss.
Looks like we're getting a little double take there. I'm going to share this first case with you, but I guess I'll need to make sure we get the. Please be patient with me as we. There we go. Share the screen again. Navigate through the technology. So this is a patient who is about 65 years old and presented with a pelvic mass. So a very common presentation for an older woman. And it was of a size that you sometimes certainly think about the possibility of malignancy. And as you can see here, you might predict that this lesion had a heterogeneous appearance on either radiology, either MRI scanning or on ultrasound. You've got some cystic spaces and some solid areas in between. At the gross bench, it was quite evident that this was a mucinous neoplasm. All of this fluid was very thick and viscous. And so we had no difficulty identifying that this was going to be a mucinous neoplasm when we saw this nice columnar epithelium with basal nuclei and a lot of cytoplasm that has sort of a pale mucinous appearance. So that's a common presentation. And of course, our discussion centers around how much more should they do? Is this a primary neoplasm? Is it a secondary neoplasm from another site? Because as you know, mucinous neoplasms can be quite variable in terms of their presentation. And here you can begin to see how in this area here, it's very simple and basally located, but then as we look over here, the epithelium becomes more complex. There's more architectural variation. You see a little bit of cystic changes, almost cribriform pattern. Here's some villus-like structures. And so there's a variability in the epithelial characteristic that is suggestive that this is not just a simple mucinous cystadenoma. For me, the differentiation between a mucinous cystadenoma and a borderline tumor is primarily cytologic. So you can get sometimes complexity with areas like this, but unless you have significant nuclear hyperchromasia or atypia beginning to form, and that's often characterized by sort of a rounding up of the nuclei, then that is the feature that I look for to say, well, this very likely could be a borderline tumor. Or as I would say at frozen section, at least borderline, because obviously sampling is very key in these lesions. And most of the areas that we're looking at here are borderline areas. You have more complexity and you certainly have a degree of atypia. that is a cytologic atypia that would suggest a borderline neoplasm. In the new WHO classification for these tumors, however, there's mention of two additional stages in borderline tumors. One is the presence of intraepithelial carcinoma, which I'm not sure that we're getting there with these areas, but I'll show you another area in this lesion, which I think would be convincing to you. Here, I've dotted the area over here. And here, I think you can see that we have more nuclear pleomorphism. Look at the variation in size. These nuclei are also quite rounded, and they have heterochromatin, nucleoli, and variability, as well as you're seeing a few goblet-type cells here, such that if this was a biopsy with this necrotic debris and this degree of atypia, you would probably have very little difficulty in calling this carcinoma. Here you see mitotic figures as well, and other features along with this. So seeing this presence, you would then move probably to the stage of either mucinous carcinoma or borderline tumor with intraepithelial carcinoma. And this type of finding certainly warrants very extensive sampling to exclude the possibility of invasive or frank carcinoma. We did do that sampling with this lesion, and we're not able to identify any definitive areas of invasion. Perhaps just looking here at the stroma, you can see that there's very little difference between the stroma around this clearly benign area and the stroma around this intraepithelial carcinomatous area. So that's helpful in recognizing that the stroma is not responding in quite the same way. Here, there's a little bit of response here around this area, but we don't have quite the same level of atypia here. So it's sometimes a little bit difficult to definitively state whether or not you have early stromal invasion. The saving grace in this circumstance is that tumors with very localized areas of stromal invasion, so-called minimal stromal invasion, those tumors have an excellent prognosis and not decidedly different from borderline tumors in general. In fact, tumors with intraepithelial carcinoma have not been stratified to identify any additional risk of adverse or statistically identifiable risk of adverse outcomes. So although we make those distinctions because morphologically these are clearly different looking types of tumors, in terms of outcome, we have as yet been able to clearly identify any difference in outcome, which is very reassuring to us and of course to the patients. So we'll go on to another case. Actually, I believe this is a similar case and may actually be the same case. This lesion, as I've mentioned, had very clearly mucinous epithelium, and my colleague correctly identified it as a, at least borderline tumor on frozen section. What was missed, however, was that there was something going on in addition in this lesion. And that, as you can see, we have a few little nests of epithelium here, another one here. And this epithelium is obviously different than the mucinous epithelium that we have over here. If we go to higher magnification, we can see that these cells are rounded, they're not producing mucin. There is a little bit of a lumen with some debris there. There's a nice basal type layer. And so this is very characteristic of transitional type epithelium in the ovary. Over here, we have more of this lesion. And you can see, again, this slight lumen formation, but a little bit more squamoid or transitional type of an appearance that you might see in a von Brunn's nest in the bladder or in a Walthard rest on the fallopian tube. And so this finding is indicative of a Brenner tumor. Now, we know that Brenner tumors, not infrequently, maybe 10% or more, will have an associated mucinous cyst. And that is a well-known association. But less frequently, we see the association, as in this case, of a Brenner tumor with an intimately associated mucinous borderline tumor, such as we have here. Brenner tumor with mucinous borderline tumor with intraepithelial carcinoma, that is even more uncommon a presentation. Now, what's the significance of this? Well, there are two things that I think are very helpful in this regard. One is that the fact that you have this association with a Brenner tumor in the ovary clearly helps to exclude the possibility that this is a metastatic lesion. And so had my colleague recognized on frozen section that we had a mucinous tumor and a Brenner tumor in the same ovary, we could have very reassuringly told the clinician that this is almost certainly a primary ovarian tumor and not something that has metastasized from the GI tract. And that would have been perhaps helpful in terms of, maybe reducing the likelihood of them doing an extensive GI evaluation and maybe appendectomy or other organ excision. So it can be helpful in that sense. The second feature here, of course, is that it's not, there probably is some molecular association of these two lesions, because it's certainly much more frequently encountered than, say, other combined tumors. And so the relationship between a Brenner tumor and a mucinous tumor in the ovary remains an interesting course for etiologic investigation and understanding of that process. Now, of course, this can also be the circumstance where you can occasionally get mucinous carcinomas arising from these tumors with an associated Brenner tumor. However, once you have that level of aggressive growth, it may obliterate the Brenner tumor. The other feature to remember here is, of course, that Brenner tumors tend to be fairly small and therefore could be missed on sampling if you weren't really thorough, or they were very small. In this case, as you can see, there was quite a lot of the Brenner tumor. I think about a third of our blocks contain some element of the Brenner tumor. So a very interesting little combination of lesions. Now, the next case we'll talk about is a patient who had several years previously had resected an ovarian tumor, and that tumor was diagnosed as an adult type granulosa cell tumor. Well, as is well known, after several years, the patient developed what appeared to be a recurrence. I think a needle biopsy was performed, which confirmed that, and she had a course of additional chemotherapy. Following the chemotherapy, there was still some residual tumor, and surgery was performed. And so we don't often see chemotherapy effect with granulosa cell tumor in the recurrent situation. And so I thought it would be interesting just to highlight this in this circumstance. I'll just take a look here briefly at the classical adult type granulosa cell tumor. As you can see, it's a very diffuse pattern of growth, small, slightly open nuclei. Maybe this is a thicker section than usual, so we're not seeing all of the nuclear grooves and other details that would be characteristic of granulosa cell tumor. But there is a degree of diffuse architecture and maybe a little clustering that would be compatible with that. Oh, maybe here we can see a few grooves here in this area as well. So take my word for it, this is adult granulosa cell tumor. And then here is the tumor that has responded to treatment. And you see there's very little architecture remaining. There's just this nice central coagulum with peripheral fibrosis, maybe a few cholesterol clefts in this circumstance. So I know that I did a video not too long ago on treatment effects in ovarian or gynecologic cancers. Unfortunately, this case hadn't come in yet, and so I couldn't include that in the series. But you get the idea that that if you just had the necrosis here, you would just say, you know, necrosis or necrotic tumor. But here we can see there are areas of residual continuing growth of tumor at the periphery of this. So that's just a very brief case. We'll go on to the next case. This is a patient who had cervical cancer. And in the course of treatment of her cervical cancer, the surgeons did some lymph node dissection, taking some sentinel lymph nodes and sending those for evaluation. And as you can see here, there are a few foci in the capsule of this lesion that are a little bit odd looking, a little bit of pale tissue right in the capsule, forming these little nodular areas. And let's see if there are more of them up here. I just don't remember for sure. So several of the sections, and this is just, I think, a single node that was serially sectioned to fully sample it. So these pale areas have a sort of defined cytoplasm. You can see a little bit of intervening myxoid tissue and very characteristic cells with central nuclei and a little bit of atypia maybe to some of these cells. So is this metastatic cancer from the patient's cervical cancer? At first glance, you might say, well, it could be, looks like that. And you could even do some immunostains, maybe cytokeratins, or even things like P63. And oftentimes these cells would light up with those immunohistochemical markers. And if you use that as a criterion to define this as micrometastatic disease, you would have fallen into a somewhat challenging and but understandable pitfall. Now, in my circumstance, fortunately, I had before evaluating the lymph nodes, I had looked at the cervix and at the endometrium. And in fact, this patient had a very pronounced endometrial decidual reaction. They didn't resect the ovaries, so I don't know completely if it was a physiologic stage of her cycle, although I think it was. And so these little foci in the lymph node look exactly like the finding that we had in the endometrium. This is what we would term deciduosis, DECIDUOSIS, I believe I got the spelling right there. In other words, these are areas of decidual reaction outside of the uterus. Now, those sorts of reactions are common in pregnant patients, but probably less frequent in patients who are cycling normally. Although patients with a history of endometriosis, of course, this is one way that that is suppressed is by using progestational agents to provoke this type of response and elimination of this tissue. So rather than diagnosing metastatic carcinoma, this was a simple decidual reaction within the capsule of the lymph node. Now, if we had seen glands here, I would have said endometriosis with decidual reaction. And I think that patients who have deciduosis without glands are certainly at a higher risk of having endometriosis elsewhere. But in fact, in pregnant patients where you do salpingectomies or something after the completion of the pregnancy, you will find decidual reaction on the surface of those fallopian tubes probably about 25% of the time. It's quite frequent in those circumstances. Okay, another endometrial case. And this is a patient who had abnormal bleeding. She was in her late 40s. And so this was a polypoid lesion that was found at the time of hysterectomy. The prior biopsy had suggested the possibility of hyperplasia. Excuse me. And I thought this was a nice example to illustrate the difference between a physiologic or secretory type hyperplasia and atypical hyperplasia. As you can see here, the glands are more closely spaced. They have some complexity to the architecture, but they also have, excuse me, I didn't get my throat cleared here. They also have a degree of secretion. The glands are dilated and the cells have this fairly ample, pale cytoplasm. So is this atypical hyperplasia or is this a more typical or not atypical hyperplasia? Well, one clue would be, can we find really any significant cells that look differently from these? And there may be one or two glands, but I wasn't completely satisfied that we really had a separate population of glands in this lesion that would show evidence of there being kind of a clonal proliferation, if you will, of this, this type of epithelium. The other feature here, of course, is we have some thick-walled vessels that suggest that this is an endometrial polyp. So the other feature which I found useful in this case to reassure me that this was a more physiologic secretory hyperplasia without atypia was to do an immunohistochemical stain. And so I did, oops, excuse me, I guess we're not going to have that here. I did a Ki-67 stain in this case and found that very useful because in this circumstance, there were numerous stromal positive nuclei, but there were no cells within the epithelium that were positive. And that would indicate to me that this was a secretory hyperplasia rather than a hyperplasia of a preneoplastic type. Okay, well, we've got another great case next coming up. This is a young woman who was 14, and she had experienced some amenorrhea and some hirsutism that was of concern. On evaluation of those virilizing symptoms, she was found to have about an 8 centimeter pelvic ovarian mass. And so any of several possibilities were considered, and that lesion was removed. Of course, they would do some serologic markers along with that. And she did have elevated levels of inhibin, and she had some other features that suggested she may have a sex cord stromal tumor. Her germ cell markers, AFP, beta HCG, and so forth, were all negative. So coming into this, they had a suspicion that she had a sex cord stromal tumor that was causing viralization. Now, at low magnification, as you can see here, we have a mixture of solid and sieve-like small glandular areas in this tumor. So sort of tubule type formation. But there are areas where these are actually forming quite nice glandular structures. And this pattern is what has been called the Pseudo-Endometrioid pattern. It is, has nicely formed glands. The cells are a little bit atypical, slightly tall. They have pale to clear cytoplasm lining these glandular structures. Now, we also have, in this lesion, let's go back here, we also have some small, more tubular type structures, as you see here, and a little bit of diffuse interstitial pattern of cells, somewhat similar in morphology. So some variability in the architecture. You can see some of these kind of nests here, not as well formed into tubules or pseudoglandular forms. So we have what looks like a tubular pattern that would fit nicely with a Sertoli cell tumor. But of course, I've been glossing over the other feature here, which as we look at the intervening stroma here, we see there are a number of these nicely rounded cells with fairly abundant eosinophilic cytoplasm. And these would fit fairly well for Leydig cells. Here you can see there's quite a few of them in this case, and they're much more admixed with this tumor than they often are. Sometimes they tend to be very focal in certain of these well-differentiated tumors. But there's certainly plenty of them here, and recognizing them, you can go on a search for crystalloids of Reinke. You may or may not find them. For example, right there, I think you've got a couple that could qualify in that category. Here's a few more over here. And these are very, very helpful if they're present, but they're only present in a minority of these cases. So you don't have to be very strict in that identification of that criterion to establish the presence of Leydig cells. When you find it, it's very useful. When it's not present, you don't necessarily have to discard the diagnosis. Now, in most cases, this morphologic finding, the classic H&E morphology would be entirely adequate to make the diagnosis. But of course, I practice in a maybe resource over-endowed environment. And so my colleague in pediatric pathology who showed me this case chose to get some immunohistochemistries. I think they're somewhat instructive and helpful to remember some of the features here. So this is the inhibin stain. And as you can see, there's a nice, clear distinction between the Sertoli cells, which are staining positively, pale membranous staining, and the Leydig cells, the interstitial cells in between these tubules and pseudoglands, which show much, much more strongly and much more intense staining pattern with this marker. So I thought this was a very nice illustration of this distinction which may at times be diagnostically useful, and particularly if you're searching for less frequently identifiable Leydig cells, using this to identify the Leydig component of these tumors might prove useful. Say if you had an area like this, less obvious cells, these more darkly and intensely staining inhibin positive cells could be a reasonable surrogate for the crystalloids, which we saw earlier on the H&E. So that's not a case that we see very frequently. I'd say in our practice, we have Sertoli Leydig cell tumors once a year or twice a year, maybe at the most, maybe not even that frequently, but the nice viralizing symptoms are somewhat unusual. Okay, well, let's go on to a new case here. And this is, you can see, is a solid tumor with nice interspersed zones of infiltrative blue tumor. And we can see that there are areas with a nice vasculature in this tumor. And it appears that this tumor is infiltrating between bundles of smooth muscle. So the differential diagnosis for this type of a tumor in the uterus would include things like endometrial stromal sarcoma, maybe intravascular leiomyomatosis, although this is with a very cellular leiomyoma component. But by and large, this and the other possibilities would be things like adenomyosis with sparse glands, things of that sort. So the vascular pattern certainly is fairly suggestive of an endometrial stromal sarcoma, along with the infiltrative pattern. As we look at higher magnification, we can see that these cells are not particularly differentiated. They're not highly anaplastic, but they do have some proliferative activity. You can see a few mitoses here, not as well seen on the digital slide as on the glass slide, perhaps, but certainly a very proliferative type of pattern. This patient was a fairly young patient, and the lesion was confined to the uterus with just a very small amount of extension into the parametria. And so it appeared to be presenting as an endometrial stromal sarcoma would, in a very confined manner. Of interest in this case, the tumor cells were positive with CD10, and they were negative with BCOR, which is a consideration with endometrial tumors where you're wondering about high-grade lesions. We did send this case for the evaluation of the JAZ-F1 SUZ12 fusion gene, and this case turned out to be negative. Now, most low-grade endometrial stromal sarcomas are positive for that fusion gene product. And so that raised consideration, particularly because there was a fairly high mitotic rate here, that this could be a higher grade stromal sarcoma. And that's why we did the BCOR staining. We also sent it for some other molecular markers that might be present in other higher grade stromal sarcomas as well. And this classification area, this area of investigation is quite active and ongoing. So you need to be aware that these lesions can be somewhat heterogeneous, and we're beginning to segregate them out. So that's why we've, if you watched my recent story about the stromal sarcomas, that's why we have the Yowie fusion gene. And that's why we also do the B-core staining and look for other possibilities in this domain of tumors. Okay, let's see, what have we got here? This looks to be an endometrial curettage. And, or at least a biopsy. And I've forgotten why I put this case in the mix here today. So you'll have to sort of see me walk through this case to see what we've got here. Ah, yes. So as you can see, this patient has a fairly bland or benign appearing endometrium. She has a history of abnormal bleeding, and they wanted to investigate why she might have that. Well, looking at these glands, they look sort of proliferative. They're widely scattered. They're generally round. So I wondered in this circumstance, why would we have a benign endometrium in a patient who has abnormal bleeding? Searching around in this case and looking at her stroma, I began to wonder if she might have an inflammatory process that would explain her bleeding. She does have occasional glandular mitoses, so there is some proliferation still going on here. But consideration, given her symptoms of a inflammatory process, was made. She had a few areas of maybe a lymphoid-like aggregate. The sections here are a little bit on the thick side. And you see a little bit of variation in the shapes of the glands. So I don't know exactly all the reasons why I felt prompted to do a CD138 stain, but I did. Oh, I guess I'm not going to be able to show it to you. I thought I'd included it here, but this is a case of chronic endometritis. Here's an area here where perhaps you can sense that there's a few extra inflammatory cells here. And as we look around, there are many times when these stromal cells can look a little bit plasmacytoid. And usually that's not something that, I think of unless the symptoms or the story is there. And here you see a little bit of breakdown along with this. And so doing the immunohistochemical stains for me is kind of a confirmatory way or a more confident exclusion of chronic endometritis in these cases. So this did prove to have some positive cells in here. And I recently did a video on chronic endometritis where I think this case was one of those that we included. And so you can refer to that video as well for a greater in-depth discussion of chronic endometritis. All right, so this case is not a particularly difficult diagnostic challenge. We'll turn it up so it looks a little bit more like we're used to looking at it. This is the cervix. And as you can see, there's a lot, at low magnification, there's a lot of dilated glandular material here. This patient had a hysterectomy to cope with her high-grade squamous intraepithelial lesion, which you can see here. And this is down into some of the glands, as you can see. And that is the simple part of the diagnosis here. So why does she have all of this mucin production here? This is much more mucin than normal. Well, as you may suggest or suspect, I didn't tell you all of the history here. But I thought it would be useful to bear this image in mind because we don't see this very often, but it can occasionally cause some consternation. So this is not a, mucinous endocervical carcinoma. We see no significant atypia here. There's no stratification. There's no above the base mitotic activity. And of course, you can get associated adenocarcinomas with squamous intraepithelial lesions. But this patient was pregnant. And so following delivery of her baby, she opted for an immediate hysterectomy. And I believe that was because there was some pregnancy complication. If I recall correctly, she may have had a placenta accreta or something of that sort. So we don't often see the cervix in terms of the gestational response in the cervix. And this, of course, is the physiologic hypersecretion of mucin to prepare the cervix and the birth canal for transit of that very large miracle that happens with the growth of a baby. So that was, I thought, a very interesting case for just awareness sake. Now, this last case that we'll do here, again, not a significant diagnostic challenge, but an interesting situation. So this patient had a myomectomy for an enlarged uterus, and was obvious that they had a intrauterine mass. And I think, as you can see here, we have some fat-like cells, spaces with clear cytoplasm, and we have smooth muscle, along with this sort of hyalinized and fibrous stroma. And so this is a lipoleiomyoma. Now, the differential for this might include things like angiomyolipoma, sort of a PCOMA type of lesion, or just a leiomyoma. And this is not usually a diagnostic challenge, but it is an important thing to remember that in patients who, that this does have a small malignant potential. And in patients who have subsequently been found to have liposarcomas in the uterus, there has often been one of these type of lesions as the underlying or related entity that was present in that uterus. Okay, well, I think, oh, one more last case. Okay. All right. So this is a patient who had a disseminated disease from a uterine neoplasm. She was a older woman in her mid-70s, and she had had a hysterectomy for a high-stage carcinosarcoma. Now, usually when sarcomas spread, it's predominantly the carcinomatous component that spreads. But in this case, this is a deposit from her omentum. And in addition to the characteristic carcinomatous features, which we have here, I think you can also appreciate that she has some areas of kind of high-grade mesenchymal-like tissue here with this very malignant appearing stromal type neoplasm, as well as having these areas of quite nice characteristic heterotopic differentiation with cartilage formation. And so because this is a little bit of an unusual finding to find all the elements, the heterotopic elements, as well as both the carcinoma and the sarcoma in the area of spread, I thought it would be useful to just share that cute little slide with you today. All right, so I'm going to open the chat for questions. Mona asks, is there a cutoff number of plasma cells in order to call endometriosis? This is an excellent question. And I would say that I can still recall Robin Young, who was one of my mentors as a resident, saying that if you have even just one plasma cell in the endometrium, that is sufficient to make the diagnosis of chronic endometritis. Whether or not that would require treatment might be a different question. And the only caveat that I would say with that is that in certain circumstances, such as with a prolapsed polyp or where you've had instrumentation of the endometrium, the presence of a chronic endometritis type of reaction pattern it should be expected and maybe frequently encountered in that setting. But in the otherwise, quote, normal appearing undisturbed endometrium, one plasma cell is sufficient to make that diagnosis. Oh, very good question from Aruj. Differentiating mucinous borderline tumor from mucinous adenocarcinoma. So the features that I find most useful in that situation are the feature of the degree of atypia and the extent of atypia. So mucinous carcinoma arising from a borderline tumor, you look for two features. You look for either pushing destructive invasion, which is very hard to categorize, but I did do a video on mucinous carcinomas and so forth that you can look up that describes that and has some illustrative slides. And then the other type of invasion is the infiltrative or microinvasive pattern that has become more disseminated. So you've got clearly infiltrative, small nested tumor cells that provoke a stromal response. With the pushing invasion, you have very minimal stromal response. With the destructive invasion, you'll see a stromal response. And when that accounts for, greater than 1 millimeter or greater than 5 millimeters, you're clearly into the category of calling it mucinous carcinoma arising from a borderline tumor. The other circumstance where you can make the diagnosis of mucinous adenocarcinoma is where all of the tumor looks like that intraepithelial carcinoma component. So if the entire tumor looks like that, you have no areas of borderline or benign epithelium, then I believe you can also categorize that as mucinous carcinoma. The catch with that is that some of those will include endometrioid adenocarcinomas that have mucinous differentiation, or possibly possibly a somatic type of mucinous carcinoma that has arisen from, say, a teratoma or something like that. And again, that differential is discussed in that video on mucinous carcinomas. But that's a very good question, and it's a vexing problem. But I would say destructive invasion greater than 5 millimeters, clearly going to be called mucinous adenocarcinoma arising from borderline tumor. Pushing invasion, where you have expansile pushing invasion that has changed the stroma a little bit, and you don't have that slightly condensed hypercellular stroma. It'll be a more pink stroma. But that pushing invasion, that's still a challenge for many people to identify. Well, wonderful questions this morning. I want to thank you for joining us. We're going to do another session next month, again in September. I'm working on arranging a guest professor to share some cases with you at that point in time. But I will hope that the subject matter and topic will fit into your interest and needs. I've done a couple of areas, so if there are particular topic areas you'd like to see us discuss, I'd be happy to see if I can encourage one of my colleagues to do a presentation for you. So until next time, thanks so much for joining me, and feel free to contact me with questions or follow up if other things occur. The link to the slides, of course, will be also posted so that you can go back and review those as well.